morning, everyone. We're going to get started. Just a reminder that next week we're actually in Pride Hall, 1930, 40, 50. We'll remind you all in the email about that. Otherwise, we'll be in car. And then another thing, very sorry, but we have been doing the sign-in to claim your attendance and CME credit. Unfortunately, that is not going to be acceptable anymore. And so I'm just going to tell you all very quickly. We will also send out a dedicated email on how to claim your credit for Grand Rounds. So essentially, you have to go into My Access, go into this continuing education portal. And if you click on it, it will link your UCSF email and make you an account. Once you have that account, you just have to text this number and we'll put it all in an email. And then every session, we'll give you a code and that will track your attendance for CME. So Anika, Seth, who's right here, and I are available if there's questions about this. Hopefully this will be easy once you set it up. And I think linking it in the My Access is pretty easy once you're in there. So without further ado, I'm going to introduce our fantastic speaker today, Dr. Monica Gandhi, who's going to provide updates on from IAS that happened in July. And I'll briefly introduce Dr. Gandhi. Dr. Gandhi is a professor of medicine and an associate division chief in our division here at San Francisco General. Dr. Gandhi is also the director of the UCSF Center for AIDS Research and our medical director here at Ward 86. Dr. Gandhi is a phenomenal HIV and ID educator, clinician, researcher, and really leader in the HIV field. And we're so excited. Her talks are always so phenomenal, and we're excited to have our second talk from Dr. Gandhi. So welcome.
Anika, just advance.
Anika or Joe.
Joe or Anika. Sorry. Thank you. It's okay. There we go. Thank you so much. Okay. Yes. So thank you for the IAS. We're going to talk about review data on the impact of the funding cuts on HIV programming, because that was a big part of the meeting. We're going to talk about treatment and prevention updates, and then mention comorbidities, specifically weight. So I think this is an apt description. That it was a little bit of an HIV conference in morning, and it has been a really difficult 2025. And there were lots of data that I'm not going to go over all of it on the impact of the US funding cuts in HIV. We all know that PEPFAR on January 24th was the date that a work stop order was put in. Lots of people put data on Secretary Rubio's desk, and that weekend, and on the 28th, there was a waiver put in for care and treatment, but only prevention for pregnant women. Then with USAID gutted, that collaborating partner, there literally hasn't been as much PEPFAR activity. And then even though it was saved from the rescission cuts at the last minute, about 4 weeks ago, the State Department, there's an internal document that the idea is to phase out PEPFAR in the next 2 to 5 years, depending on country. So this was presented, Dr. Havler talked about this last week, the UNAIDS update at the IAS meeting. And it is important to say that 40.8 million people are living with HIV, 630,000 deaths, 1.3 million new infections. None of that has actually changed in the last 3 updates. And 73% virologic suppression rate. This is, of course, data in 2024, so prior to the US funding cuts. And I'll just say that there were modeling in that global UNAIDS report that we're going to be back to sort of 2000, early 2000 levels, unless we can help level out these number of new HIV infections from the cuts. So at present, which domain of HIV does the US funding cuts do you think have the most impact? Do you think it's on diagnoses, HIV treatment, HIV prevention, or the development of INSTI-based resistance? Okay, so here, the majority of you are saying HIV treatment, though prevention and diagnosis are up there. Actually, it depends, and it's likely that it's across all 4 domains, but I will say that the biggest impact seems to be on prevention, even as Chris Beyer predicted in as early as CROI 2025. So it is true that treatment is being affected. And in fact, this was April 10th guidance by the World Health Organization in 2025 to say, what do we do when there are stockouts and drug shortages? But as Dr. Havler told us last week, there are many countries who are taking on treatment, who the ministries of health are buying and distributing treatment. And it really does look like prevention is the most effective. This was presented at the co-chair meeting, and you know that the co-chair meeting are often the most important or sort of most notable abstracts. And this was depressing because this is actual data from Mozambique, where over a year period, there's a 25% reduction in ART initiation in adults. And among those on treatment, reduction in viral load tests performed, test results received, and virologic suppression. And that was worse for children. But in general, many countries, again, are taking on their treatment. And it's really PrEP that is being so much affected by the PEPFAR cuts, because prevention is only being distributed for pregnant women in the PEPFAR program as of January 28th. And this was analysis across multiple countries. And really the idea, that showed in that UNH report, is that there's going to be a lot of new HIV infections and a rise in HIV incidence unless other funding sources can be identified for PrEP. And we'll talk about lenacapavir next, or at some point in this talk. And certainly lenacapavir is linked just recently over the last couple of days with PEPFAR. So this and all of what's been happening this year led to many people in this room and many people around the world signing the Kigali Declaration. And the idea was that over 4 decades, we've had improvements in the HIV response, and we're at a very critical point where we need stakeholder involvement, where we need countries to take on treatment and prevention. And these cuts are real and happening and don't seem to be getting better. And the 5 tenets of the Kigali Declaration are to embrace meaningful partnerships, support HIV global research, prioritize prevention, which speaks to what we just talked about, protect human rights, and importantly, reject the politicization of science and use science-based ideas instead of conspiracy theories. So let's talk about where we are and what came up for HIV prevention at IAS 2025. Now, this actually leads to a question that I have for you, which is, how many additional infections beyond what were reported in the New England Journal papers for Purpose 1 and Purpose 2 on lenacapavir have been seen? And I will give you a hint that this should have been presented at IAS, and this is not presented at IAS, and you have to go to the package insert and find out by word of mouth and then write Gilead about this. So unfortunately, these were not presented, but was it 1, 2, 3, 4, or 5? And this is combined across the 2 trials. So these are, of course, additional infections. We would have been interested to see their trajectories, their viral loads, their resistance pattern. This should have been presented probably by CROI 2025 even, or IAS 2025, but unfortunately these were not presented. But you can find them in the package insert of lenacapavir when the guidance, when the FDA approved it on June 18th, 2025. So I'll let you know as we go ahead. So remember what the Purpose 1 study was. It was not presented at IAS 2025. It was presented at IAS 2024. And the New England Journal paper came out at the same time. But there's been lots of data that have come out from Purpose 1, including at IAS 2025. Remember, the original design of Purpose 1 in cisgender women was a 2 to 2 to 1 design of lenacapavir in over 2,000 women compared to FTAF in a 2 design, and then FTDF in the 1 randomization. And these were young women. So the average age was 21 and went down to 16. So that means that there was also a lot of sexual risk because there was a lot of STDs. And so we're going to get pregnancy data, and I'll talk about that in a minute. And importantly, even though this was a study performed in Uganda and South Africa, and PrEP was available, oral PrEP, only 6% of women had access, 6 to 7% had access to oral PrEP. So you've seen this many times. At 52 weeks, there were 0 infections in the lenacapavir arm, but there are actually 2 new seroconversions that have been reported in Purpose 1. And again, those came out and only in the package insert. Would have loved to see this data more detailed at IAS, so I'm pretending it was presented at IAS, which it should have been. One of the incident HIV infections occurred with someone who had stopped lenacapavir, and the other one, the viral load was too low to genotype. So don't know if there was lenacapavir that resistance that developed in that second seroconversion. The injection site reaction frequency remains the same, and there's lots of nodules. So then remember, Purpose 2 was performed in men, and this was also in gender diverse individuals. And the original data had said that out of 2,180 men or gender diverse who had received lenacapavir, there were 2 infections that were presented in the New England Journal paper in October. But then an additional seroconversion occurred in Purpose 2. And in this case, there was an ability to genotype this particular virus, and there was development of lenacapavir-associated capsid inhibitor mutations. So Q67 and K70R. So this was approved in this country on June 18th, and we're going to talk about what the WHO said in terms of the use of lenacapavir worldwide and how to monitor. And that came out at the meeting as well, because the updated treatment and prevention guidelines from the World Health Organization really coincided with the Kigali meeting from July 13th through 17th. So my next question to you is, can lenacapavir, please keep in mind that this data is pharmacokinetic, can lenacapavir be co-administered with rifampin for TB treatment? So no, CYP3A4 interactions are prohibitive. Rifampin is a really powerful CYP3A4 inducer, and that will make lenacapavir levels too low. Or is it yes, it's fine, no dose adjustments needed? Yes, but give an additional half an injection. Remember, lenacapavir is given at 927 milligrams and 2 1.5 mil injections. So if you just give one 1.5 mil injection, that's 463.5 milligrams. And as long as you give that when starting the rifampin, you're fine. Or is it 4, give an additional 2 oral loading doses of lenacapavir when you start the rifampin? Or is it 5? We don't know yet. So please vote on the co-administration of what we're going to do with lenacapavir prevention with rifampin, or in the setting of TB treatment, typical TB treatment. So this is good because the majority of you did say don't know, or this doesn't seem possible because lenacapavir goes through the CYP3A4 system, and RIF is such a powerful inducer. The answer is actually D. And I'll tell you that, again, this is pharmacokinetic data. And if you've taken a look at the package insert of lenacapavir, it's pretty complicated. And there are all these things that seem to be able to be done, and we're going to have to go on PK data. And this was presented quite simply and in nice graphics by Linda Gail Becker at IAS. So I'll walk you through TB treatment with lenacapavir. I also want to say that Dr. Becker is speaking at the CFAR seminar, which follows right after this. So it's at 10 a.m. to 11 a.m. online for you to get back to your offices. And please do consider joining our CFAR seminar. So the typical dosing of lenacapavir for prevention or treatment is that 600 milligrams on day one, so let's call it day 1 and 2. So it's 300 milligram tablets. And so you take 2 tablets on day 1, 2 tablets on day 2. And then if we call day 1 the first day of oral loading dose, that's the day that you give the 927 milligrams of lenacapavir. Unlike cabotegravir and its oral lead-in, it is absolutely mandatory to have the oral loading. And this is what I see as the biggest concern in prevention, is that we're going to need to either watch someone take their second dose or ensure that they do, or really tell them that the next day they have to take it, because without that oral loading dose, you simply do not get to the protective levels very quickly. And so really you get protection on day 2 if you have that oral loading dose. So that's the first really important point, and that's logistically what we have to think about worldwide. And then in terms of rifampin, and actually I'll mention rifabutin as well, at least what it appears from the PK data is that you can give it with rifampin, but number one, you have to be at least 2 days into your starting of your lenacapavir. Don't do it right on the first day. And then you give 2 additional oral loading doses on days 1 and 2 of giving the rifampin. Say you start that rifampin at 600 milligrams, like on day 20, you're going to give an oral loading dose of lenacapavir that day, day 0, that day of rifampin, and the next day. So 2 600 milligram loading doses. And actually, since rifabutin is not as powerful as a CYP3A4 inducer, there is a way to give it with rifabutin as well. And in that case is when you give the subcutaneous injection, so the 463.5 milligrams. Complicated, but I think the PK data does actually play it out. We don't show it, but it's in the package insert. So other data that was presented from Purpose 1 at IAS 2025 was the pregnancy data, because we had some in the New England Journal paper, but by this time with the open label extension phase, there were 184 pregnancies in the lenacapavir arm. And there were some spontaneous miscarriages or abortions or stillbirths, but they actually weren't any different than in the lenacapavir arm than they were in the TDF-FTC or TAF-FTC arm, and not really different than the general population. So even though the CDC guidance for lenacapavir, which is going to come out on September 18th, and I'll give you a preview of in the next ARS questions, are going to say, quote, shared decision-making in pregnancy. I think this is enough data that I feel really safe with lenacapavir in pregnancy. Also, it's just interesting to think that there's just some element of crossover to mother to child with different antiretrovirals. And it really has to do with protein binding and distribution, but there's very little crossover during breastfeeding to infants. So even though there's plenty of lenacapavir in breast milk by the PK data, there's very little transfer over to the infant, which is, I think, actually a good situation. Okay, couple of other points, then we'll come back to lenacapavir in terms of guidance. Not that it came out at IAS. It did come out, though, with the WHO treatment and prevention. But one other important prevention update that came out of the meeting is that the PILLAR study, I think, is really a good study, because the PILLAR study really looked at the rollout of cabotegravir. This was presented at CROI 2025 in different high incidence counties in the United States. And this was the data from CROI that out of 201 men who had sex with men, that there was a lot of racial and ethnic diversity, and everyone seemed to like cabotegravir. This actually kind of mirrors the data that Matt Spinelli put together for our clinic of 111 people on cabotegravir that was just published in June, and some other SFHN clinics. But this was high persistence. So month 6, 85%, and month 12, 73%. So people were staying on that cabotegravir every 2 months in these high incidence HIV counties in the United States, and there were 0 HIV acquisitions. So there were STDs. So if you're going to give cabotegravir, then give doxypep as well. But what got presented at IAS 2025, there was really the question of why people liked cabotegravir. Why were these outcomes better than we had seen with the rollout of oral PrEP in terms of persistence? And essentially, you can see that it was really oral PrEP where people were worrying that sexual partners would find out, or that people will think you have HIV, or your privacy would be compromised by having that TDF FTC at home. But all of those went down, those stigma parameters went down with the use of long-acting cabotegravir, and people were happy. I mean, they liked it. They really did prefer cabotegravir to oral PrEP. So that was the data that came out of IAS 2025 on cabotegravir. Okay, so this is going to be you sort of thinking of the public health approach for lenacapavir. What do you think we're going to do in this country? What do you think are going to be the guidance worldwide? So what does the WHO recommend for HIV testing prior to the use of lenacapavir? Do they recommend HIV RNA testing at initiation? Well, prior to each injection? Or is it, and that means even at initiation, or is it HIV RNA testing at initiation, then once yearly, but HIV antigen antibody testing in between? Or is it throughout HIV antigen antibody testing prior to initiation and prior to each injection? Or is it number 4, HIV RNA testing at initiation, but then after that, rapid antigen antibody tests? So please vote. And remember that the WHO put out their guidance for cabotegravir in July of 2022. So cabotegravir has been on the prevention guidance at the WHO since July of 2022, not ART. We'll talk about ART, but and you know what they did for, well, I'm not going to tell you because I think it's the same, but you know what they did for a testing guidance for cabotegravir. So that may help you think about what they put in for testing guidance for lenacapavir. So actually, at this point, more than half has said HIV RNA testing at initiation, but then after that, antigen antibody testing prior to each injection. And then we can add up that, let's say 20% of you have said HIV antigen antibody testing at each injection, including at initiation. So the answer is actually HIV, it's actually C. And unless you've had a known exposure, it is really the rapid testing. And this is consistent with a public health approach. And I'm sorry that the font changed on all of this. So I did want to say that some prevention the prevention and treatment guidance were updated, and it coincided with the meeting from the WHO. And in terms of prevention, lenacapavir was put on the prevention guidelines, and it is, unless you've had a clear exposure, HIV antigen antibody testing at initiation, and every 6 months, which I think is consistent with what makes sense in a cost-effective way. Now, what do you think the CDC is going to recommend? CDC guidance is going to come out on September 18th. So today is the 10th, so in a week. What do you think they're going to recommend? I do know what they're going to recommend. So what do you think they will recommend? Will it be the same as the WHO guidance, or you think it will be something different? So these are the exact same 4 answers that you had looked at before. So you're pretty familiar. So you can just put in if you think it's going to be the same or different in this route, in more of a, let's say, high resource setting, but then again, in a very cost cutting time. So as you're answering, this is looking actually like you're tilted more towards HIV RNA testing at initiation and then antigen antibody testing at each injection, which is 57% of you had said that for the WHO guidance, but in this case, 70% are saying it for the CDC guidance. And then lower numbers of you were saying, 20% of you had said what the WHO ended up saying. So you're right, actually, it is D. So the CDC guidance is going to change from what the WHO recommends. So RNA testing at initiation and then antigen antibody testing. So I think that's actually also fine and really consistent with what the cabotegravir guidance by the CDC is going to change to. It is still unfortunately listed as RNA testing every 2 months, but they are going to change it. Likely, I think it's going to, I'm not sure. It's possible come out with the same MMWR paper that's coming out in a week. Okay, let's turn to HIV treatment at IAS 2025. So there were updates on treatment, and I would say that they were really in the area of long acting and also some new drugs. And then I do want to make mention of a 2-drug combination, which we're all familiar with. So dolutegravir 3TC, remember, it was studied a long time ago and is on the US guidelines. And this was the original trials where the Gemini 1 and 2 study, the phase 3 trials. Remember, it was like paddle, and then it was 5353 and the ACTG, and then we got the phase 3 trials. And the Gemini studies, I want to remind us that actually there was an exclusion criteria of not having a viral load greater than 500,000. So when you look, for example, at the DHHS guidelines, there's that exclusion of not using dolutegravir and 3TC with high viral loads. And, it looked fine as long as you don't have any resistance at baseline. And specifically, I wouldn't ever accept an M184V, at baseline to use dolutegravir 3TC. And it looked like not only in Gemini, but the Tango and Salsa studies also looked at switching from 3 to 4 drug regimens to dolutegravir 3TC and maintained suppression. Now, big caveat, I will say that last year I put a big X on an IAS 2024 study that I wanted you to ignore, which was the one by Gary Blick that said it's fine to use dolutegravir 3TC with an M184V. That data was not sound. And I would put a big X in front of anything that you'd hear on a report that you can take antiretrovirals 5 days a week and just skip the weekends. You saw it coming out of IAS 2025, and that's a big X. So we don't pay attention to studies that aren't sound. So what did we find out about dolutegravir 3TC at this meeting at IAS 2025? Well, this is an interesting study called the Volition study. So there's some element of choice here, but what the study design of Volition was that this was a phase 3B study where naive participants were first started on dolutegravir 3TC, got suppressed for 16 weeks, and then they could choose to switch over to cabotegravir rilpivirine long acting. Now, the only data that was presented at IAS 2025 is those first 16 weeks. So we're really just going to pay attention to dolutegravir 3TC in this big study in low and middle income countries. And importantly, they also had a choice whether to switch over. So there was some element of data that I'll show you that how many people wanted to switch over. No hepatitis B infection was allowed in, of course, to a dolutegravir 3TC trial. And this kind of sounds like FLAIR, right? Like in FLAIR, everyone was naive, and then they got dolutegravir, abacavir 3TC, and then switched over. So the important thing to mention is that there was no restriction on viral loads to enter into the Volition study. So you could have viral loads that were greater than 500,000. There are only 15 people, but of these individuals, people did fine, even if they had a high viral load. So I think that's the only new information that this provides us, that across CD4 criteria, different strata, across different viral load criteria, dolutegravir 3TC led to the achievement of virologic suppression at the same rates. And there was one confirmed virologic failure, and these were 171 individuals. So pretty high rates of virologic suppression, as we saw with Gemini, but knowing that there were no restrictions when the WHO put in their guidance, which I'll tell you about in a bit, that dolutegravir 3TC has now been added to the WHO guidance, no restrictions on viral load. So that's what volition taught us. And the other thing is that they called it DOC, day of choice. So after the 16 weeks, you could say, okay, do you want to go on to long acting or do you want to stay on dolutegravir 3TC? And 155 out of the 171 said, I want the long acting. And now we'll see the results of those at a subsequent meeting. But 70% said it's because it will make my life better. 67% has said because I'm mobile and I want to travel, and that's important to have the long acting for me. And then others just said, I actually feel like I have more autonomy. So these were interesting answers to why people would want to be on long acting. So we'll see volition later, but there were 3 big studies on long acting ART that I want to tell you about at IAS 2025. And those are going to be the Beyond study, update from the OPERA cohort in those who start long-acting ART with viremia, and then the Impala study, which I think was a really important study, actually. So the Beyond study is, the study design here is that these are US-based individuals who were put on long-acting cabotegravir and rilpivirine. So in this case, it was 27 sites across the US, so real-world study. I will warn that you can tell by the font that this is a ViiV-sponsored study. They always kind of have this look of their slides, and so I always want to tell you when these are sponsored by the drug company, but this was performed from September 2021 through July 2022, and everyone had to be an adult. But this is the important thing: some people were put on it if they were viremic, so they called those individuals IWL, inconsistent with label. Real world studies. So some people were put on Cabril, even if they were viremic and even if they had, say, resistance in the past. So this is the kind of population that we are more used to looking at and our splash cohort at Ward 86. So that's why I wanted to present it to you, because this is additional data on the use of Cabril in those with viremia, which again, we have no randomized controlled trial of the use of long-acting Cabril in viremia. There will be one coming called the Crown study that's randomized, but all the data we have so far is really from our center and others in the setting of viremia. So 308 people, 27 US sites, and most of this quote IWL, this is not consistent with label, was those who started long-acting Cabril with viremia. And it was pretty diverse population, Medicaid 26% at least, and diverse in terms of race. And this was the population. Okay, so looking just at the results, really high rates of virologic suppression are based on the last recent viral load, but let's focus in on that purple one. The purple is IWL, that means inconsistent with label. And there were high rates of virologic suppression, even if you started with viremia, 91% if you started with viremia in the 44 people who did. So it adds to the database. We have 129 people that we've presented on with viremia, and this is 44, and they had high rates, over 90% of virologic suppression and this was, by the way, 24-month data. So this is 2 years. So this adds to the kind of database of what we've observed here at Splash, and also a CID paper that Ponce Clinic put in from that just got published this month from Atlanta, that our look at it, which was presented in March in a JAMA paper. This was of the 129 people who started with viremia, 98% virologic suppression. But in the Ponce data, 81 people started with viremia, 2 dropped out, so it ended up being 79, and there was a 92% virologic suppression rate. So after 3 doses. So we're kind of at these over 90% in the real world with those who start with viremia across these different observational databases. What about OPERA? Because OPERA at every meeting seems to present the data on the fact that people do use long-acting Cabril and those with viremia. So this is, remember, the OPERA is a real-world electronic database. electronic health record. It represents about 14% of people living with HIV in the US. And a lot of people are on long-acting ART at this point, 3,304 in OPERA out of 151,000. But honing in on that orange, 368 or 11% had started long-acting Cabril with a viral load of greater than 50. So then the question is, what's the viral load outcomes in those participants in OPERA with viremia? And at least in the most updated that came out at IAS 2025 of this data, there was kind of 59% on time. So people don't come in on time a lot. 33% were delayed, or 11% or 13% missed. So that's worse than what we've seen in our center, I have to say. And then in terms of virologic suppression, they waited to see if there was more than one viral load. So if you look at people who had 2 viral loads during follow-up, which are 313 out of that 368, the virologic suppression rate achievement, right, because they started with viremia, was 82%. So it is lower than we've seen of those over 90% in PONCE and our setting and beyond. And we have to watch that. And this is probably closer to just people stopping and discontinuing and our ending where we've ended up actually in the SPLASH cohort, and probably where PONCE has ended up too. So in the first 3 years, 85% achieved virologic suppression. That's still better than a paper that was just published in CID this month from Ken Friedberg's group at MGH that looked at, well, what if you stay on oral ART and you have a hard time taking oral ART? And even with wraparound services and doing everything you can, the virologic suppression rate is still around 48%. So if you just insist on oral ART, that is still not as good as giving people long-acting ART who really can't take oral ART. They also did a sub-analysis at IAS 2025 and OPERA of the women. Women have higher PK levels of cabotegravir, it seems, just across different studies, including the Swiss HIV cohort study. And they did the same as men. So same kind of 85% virologic suppression rate. Okay, so then let me ask you, what's the only randomized study which was performed prior to Impala on long-acting ART in those with adherence challenges? So everything I just told you was observational, was not randomized. So what's the only randomized study before getting to Impala, which we're going to talk about next? Was that the MOCA study? Was that our data? Was that Atlas 2M? Was that 5359 or the Carousel study? So good. It's not ours because we're observational, and Atlas was not an adherence challenged. And Impact MOCA is a single arm study among adolescents, 140 adolescents who got put on Cabril when they'd had a lot of treatment experience. So the only randomized, and Carousel is a real world rollout program in Europe. So it is 5359. That's the only randomized study. And remember, 5359 really, it does not look at viremic individuals, even though 17% of people stuck in with viremia. So remember the 5359 results. This was is about to come out in a major journal, but I can't, it's not yet totally accepted, but this was presented at CROI 2024. And remember that everyone really needed to get suppressed, even though they had adherence challenges in the past, prior to the randomization to long-acting Cabril versus staying on standard of care. And that suppression occurred with conditional economic incentives. And again, 17% were still viremic when they went on to the long-acting. But this was stopped early on February 11th, 2024, and presented just 3 weeks later at CROI because the results were really exciting. There was a randomized study, and there was superiority in those who got randomized to long-acting ART in terms of virologic failure, 7% virologic failure in those who were on long-acting versus 25% in those who stayed on oral ART. So that looked superior. The long-acting looks superior in 5359. So what's the Impala study? This is the next randomized study that looks at people who have had adherence challenges in the past. And importantly, this was done in Uganda, Kenya, South Africa, so places that do not have access to long-acting Cabril, which is tragic. And but it was those with adherence challenges, which is exactly the population that we've always thought we want to use long-acting on. Now, it was actually closer, however, to the design of 5359 in the sense that everyone had 540 people randomized. Everyone had adherence challenges in the past, as represented by HIV viral loads greater than 1,000, or skipping clinic, or not coming. But then during screening, they had to be virologically suppressed. So just like 5359, they had to make them virologically suppressed with paying people. The entry criteria is that you did have an HIV viral load of less than 200 over the 3 months prior to enrollment. So then got randomized to long-acting Cabril versus 2 NRTIs plus dolutegravir. And what this study showed us, okay, importantly, I'm going to talk about hepatitis B in a minute, but this study showed that during the randomization, that essentially half, 271 went to Cabril and 269 went to oral ART. And just like the CARES study, lots of women, 60% women, because this reflects the demographics in the region, Uganda, Kenya, South Africa. Hepatitis B core antibody positive, 31%. And we'll talk about that if they weren't immune, they were excluded. And I'm going to mention that in the next slide. And high BMIs, 22%. That looks like CARES. They had greater than 20% had high BMIs. And lots of prior exposure to NNRTIs. Remember, it was 73% in CARES, 78% in Impala. So that just means you probably have a lot of archived resistance in your reservoir, and it probably doesn't matter. There was zero genotypic screening here. So the results showed that essentially there was non-inferiority between long-acting Cabril and those with adherence challenges in the past versus TLD, essentially. So 91% in each arm. So not superior, but the same. And I'm going to get into hepatitis B, but I thought this was really good data, really interesting data that long-acting, can achieve such high rates of virologic suppression, super treatment experienced, lots of adherence challenges in the past, and really high 48 weeks rates of suppression on Cabril. So there were 5 confirmed virologic failures with 2 HIV viral loads confirmed as greater than 200 in the Impala study. Remember, it was 540 people and 271 in long-acting Cabril. So 5 people had confirmed virologic failure. This looks exactly like CARES because they couldn't sequence 1 and they could sequence the other 4. Remember, CARES had at 96 weeks 4 failures and they could sequence 3 and not the 4th. So they could sequence 4, and all 4 had NNRTI and INSTI resistance. So even though all resuppressed on TLD, that is not our practice at Ward 86. Our practice is to use darunavir-based regimens if you have INSTI-based mutations. And please do not believe any hype that INSTIs, bind differently to integrase. I really feel more comfortable using PIs if you have INSTI mutations until we get more data on this. Okay, so Impala excluded those who are hepatitis B surface antigen positive and hepatitis B core antibody positive without immunity, without documented greater than 10 international units per mil hepatitis B surface antibody. So what percentage of the screen population did that represent? Was it 30%, 20%, 10%, 5%, 1%? This is not even done in the public health setting, meaning we had to say that, of course, this was a study design and this got done, but I think the conclusion that you're all going to draw is, I wish we had more, and we need to have more hepatitis B vaccination. But so what percentage did that end up excluding out if you were able to get all these serologies in the real world in these 3 countries? Is it 30%, 20, 10, 5, and 1? So the majority of you, 63%, are saying 10%. And that is accurate. And I did have that little 10 after the answer because I made a mistake. So yeah, that's right. So 10% did actually have, of those 540 individuals, 10% either, 7% actually had, sorry, it was a total of 10%. And I'm trying to remember the distribution, and I'm not sure which way it goes, but I think it was 3% had chronic hepatitis B and 7% had prior HIV, hepatitis B infection without immunity. So 10%, you're going to have to be excluding. That already makes you nervous in the sense that you need to be able to get these serologies prior to using Cabril, or more importantly, I wish we need better hepatitis B vaccination rates, right? And so what ended up happening in the Impala study? Well, you've already excluded those who would be most likely to reactivate. So we're the reactivation and or incident hepatitis B infections in Impala. Okay, sorry, yes. So it was 3% of those who had active hepatitis B, and 7% had been exposed and weren't immune to hepatitis B. So the results were that actually there were no reactivations, which made sense. You did all the right screenings to avoid reactivation, but there was one incident hepatitis B infection in the group that got long-acting Cabril. 32-year-old male got significant elevation of liver enzymes, which is what triggered the evaluation for hepatitis B, and had new hepatitis B infection, and was switched to a TDF 3TC containing regimen and suppressed, but now has chronic, now has hepatitis B. So it just really speaks to, if you give it widely without doing the screening, then that's of concern. And because so many got screened out, and I think the biggest goal is, of course, more widespread hepatitis B vaccination. So all of this data put together, really also a big fanfare at the meeting was, I already told you, the release of prevention guidelines, WHO, and treatment guidelines. And what were the three big things on the treatment guidelines? Cabril is now on the treatment guidelines. Since 2021, lots of requests of the WHO to put Cabril, but very fairly, I think, needed the CARES data, which is in low and middle income settings, needed Impala, which was in low and middle income countries, and also needed more access, which were not there, but long-acting Cabril is on the guidelines now. Second is 3 is a drug option on the guidelines. Again, very caveat worry about having M1B4V. And so we're going to have to see. Brazil is switching over to dolutegravir. Why do you still have added lopinavir on the guidance for PIs? Just because the NADA study had shown that darunavir really is the PI of choice, and all those Donnings, Vicen, 2SD, Nadia, cut it. Absolutely the PI that has been put as the PI of choice. So that feels good to have darunavir on there. A couple of more studies with the idea that I would like 5 minutes for questions. So I may actually just kind of skip to the comorbidities so we could have those questions. I will say, I think Odyssey is important though, because this is a study in children, and you're not surprised, but children, and so does everyone, need dolutegravir based over old regimens. And the formulations, Dr. Havler talked about this last week, have been getting better. It used to be just awful. Can you imagine drinking ritonavir when you're 2 and what that tastes like? So dolutegravir has been getting better and better in terms of the liquid formulations. And essentially the question in Odyssey was, in this trial design of standard of care, we shouldn't even say standard of care anymore, versus dolutegravir based ART, what came out as predictors of failure for these children. And dolutegravir did better. That's just the most important thing to say, is that you can see that your failure probability was higher if you weren't on dolutegravir. That's really the strongest predictor of doing well in children. So that's not surprising, but really important data that dolutegravir needs to be first line, across the board. And additional baseline predictors of treatment failure were having a low BMI for age, or starting late, right? Having a low CD4 cell percentage, or WHO stage 3 to 4. So, start as early as possible. And we all know that the outcomes among children still are not where we want them to be, but dolutegravir needs to be the drug. Okay, so this is my next question for you, because this got a lot of attention. I thought it was an inordinate amount of attention, maybe for something that's so early in development. But what is MK-8527? Is it a new capsid inhibitor that's going to be used for treatment and prevention? Is it a new NRTI? Is it a new NRTTI? Or is it a new INSTI? And whatever it is, it's going to be studied for both treatment and prevention. So that's true. So people are saying 67% are saying NRTTI, you mean nucleoside reverse translocation transcription inhibitor. And you are right, 57% of you are right, but some are saying capsid inhibitor. So it isn't new NRTTI. And remember, we don't have any NRTTIs yet that are marketed. Islatravir is the closest, and islatravir had all those issues with reduction of total lymphocyte count and white blood cell count, and so now settled on a 2 milligram dose per week. And so it needs to be the right dose. So then what's this cousin? 8527 is supposed to be the cousin that doesn't have problems with lymphocyte count, so that you don't have to be so scared about dose. So what was this? This was just a dose finding study that was presented at IAS 2025. So it was individuals who are low risk of HIV exposure, and they were randomized to receive different doses of 8527. And it was 3 milligrams, 6 milligrams, or 12 milligrams. And importantly, it was per month. This is how 8527 is going to be studied for treatment, is one dose of an oral pill per month. That's what they wanted for islatravir, but that study had to be closed down early because of all the reduced white blood cell counts. So, so what did this show us? It essentially showed us that across any of these dosings, even up to 12 milligrams, that there weren't any severe adverse effects. And importantly, what we care about, right, is total lymphocyte or CD4 count. And even going up to 12 milligrams orally once a month, there weren't concerns about reduction in white blood cell count. So this may be the cousin that we want of, and of islatravir, when we're not so worried about dose. And remember, the NRTTIs are actually intracellularly phosphorylated. So when you look at levels, you look at plasma levels and also intracellular levels of 8527 triphosphate. And there was a dose, proportional concentration. So 12 milligrams had the higher concentrations. So the two big studies that are going to happen are called Expressive 10 and Expressive 11. And they are the PrEP trials that are launching. They are big PrEP trials. Look at these 4,000 numbers. This is actually comparing to, these are the kind of numbers that we saw with the Purpose 1-2 studies, that we need these kind of numbers to look at actual reduction in HIV incidence. And it's going to be go into a once monthly dosing for prevention. And then there are going to be phase 3 trials of treatment with MK-8527, and the treatment's going to be once a week. Remember, islatravir is given once a week at 2 milligrams with lenacapavir 300 milligrams. So 8527 is going to be given with either doravirine, because that same drug company makes both, and lenacapavir if they get there. And then one other comment about a new drug, which is a new non-nucleoside reverse transcriptase inhibitor, and it's called ulonarvine. And ulonarvine is being given with islatravir, so you can imagine that it's made by the same drug company as islatravir. And you know how islatravir is being studied with doravirine? This is just being given with ulonarvine, so it's a new NRTI. And again, just a dose-finding study of ulonarvine. And you know what happened? Because they were using the higher dose of islatravir, which was 20 milligrams, everyone got reduced blood cell counts. So now go back to the drawing board and use ulonarvine with the right dose of islatravir. Okay, final comment on comorbidities, and then I think we'll have a few minutes for questions, which is really the big study I want to tell you is, or ask you first a question, is to switching to doravirine if you have a BMI of greater than 30, does that lead to greater weight loss among people with HIV starting with obesity? So yes, but you have to give the doravirine with TDF, or is it yes, but only if given with TAF, or is the answer no, not additional weight loss, or is the answer yes across the board, whether it's TAF or TDF? So we all know this is the DO-IT study, and the DO-IT study 5391, the ACTG, was presented at IAS 2025. So the majority of you are saying the right answer, which is no. So doesn't look like when we think about switching people to different meds, nothing is really panned out. Exercise, nutrition, GLP-1 agonists, but nothing's panned out in terms of going to switching, not really significantly. So the 5391 study design was individuals who had a high BMI greater than 30, so a definition of obesity, and been on regimens for 48 weeks, and then switched over to either doravirine with TAF, doravirine with TF, or continuing on the INFD with their TAF FTC. And essentially, all three arms lost weight, actually, but no, and they knew that this was a weight study, but there were no significant differences in weight change, whether you got switched to doravirine with TDF, which is supposed to be weight suppressive, or doravirine with TAF. So just know that that did not change outcomes, at least if you have a high BMI at 48 weeks. And I only want to mention one other thing, and I'm going to stop. I really like this study, TCANE, which is a randomized trial, topical trichloroacetic acid versus electrocautery. This is that direct comparison for people with anal intrathelial neoplasia. And it was actually a pretty big study, 130 essentially in each arm. And there were similar outcomes with the application of TCA versus electrocautery, which can be, really require specialized training to do cautery. So I'll end there so that we do have, I think, like a couple of minutes maybe for 2 questions or something. Okay, thanks. Thank you.
Thank you, Monica. Let's bring the mic and we'll see if there's any questions. There's a few questions online. One is, can you just review the data on M184V and dolutegravir and 3TC? The person was asking about Solar 3D, which showed similar efficacies. Just wanted to review your concerns.
Yeah, so that Solar D3 study was presented by Gary Blick last year. And essentially, there were, I think, multiple concerns with that data. Most people had been switching from dolutegravir bacavir 3TC to dolutegravir 3TC. We didn't have enough of a period of follow-up to say that if you have an M184V that you're going to be able to maintain suppression. And we all know what dolutegravir monotherapy does. It's not a good look, and I just wouldn't do it. Like, it's just, it was, I would ask you to review both Laura Waters and Trip Gulick's questions to Gary Blick that I think decimated the presentation last year in Munich.
Super helpful. And then in the CAB-RIL studies across sort of real world studies, are people, do we have a differentiation between like baseline viral loads being very high, not so high? Can you comment on that?
That's such a good question, because no one has, remember I presented in the last HIV Grand Rounds I gave on long-acting ART, a meta-analysis that was presented in December 2024 in CID of 9,224 participants who are on long-acting CAB-RIL across 33 studies. And of those, about 900 were started with viremia. And there was no distinguishing in that meta-analysis of those who started with high viral loads versus low. In the SPLASH cohort, I would say that we have to be, it'd be a very nice and important thing. Maybe we can do it for Croy, Matt, or Matt, to look at those who started with high viral loads versus low and how they did, because we haven't actually stratified. Like, say you start with 100, greater than 100,000. I think of all the databases, probably SPLASH is the place to look. But I think there's 2 reasons why you don't get down to maybe where you need to get down to. One is PK, and we just need more PK. And one could be the reservoir, because if you start with a super high reservoir, generally if you start long-acting Cabril, they've had a lot of treatment experience. So they may have a high reservoir, and maybe if you have a high reservoir, you can't get all the way down. And maybe having a high reservoir is implicated by having a very high viral set point. So we need, I think, PK and reservoir studies. And if anyone's on the study section for our grant that we just put in, please review it well.
Okay, and we'll take one question from the audience, and then we're going to have to stop.
For lenacapavir's PrEP, with the WHO guidelines, not just saying that like antigen antibody alone is okay, but rapid tests alone are okay. I'm wondering how you feel about potentially doing that in like domestic settings where people don't always want to get labs, either at baseline if maybe we got labs and then they came back for their actual injection like a month or two later, or a few weeks later, or as maintenance. So that's like basically rapid and
yeah. I mean, to be fair, to two things. One is that if you think you've had a recent exposure, the WHO guidelines do say RNA. Second is that in our setting, I think we can't afford HIV RNA testing at initiation, and at least extrapolating from 083 and 084 with cabotegravir, the worst thing you can do is start it with acute HIV infection. So in terms of actually, getting resistant. So I kind of like the HIV RNA screening. On the other hand, lenacapavir 5 total seroconversions across 2294, I think, in Purpose 1 and 2180 and Purpose 2 who were on lenacapavir. So it is kind of a lower rate of seroconversion. I would say I would push, and I think our guidance, and we're gonna do this in the next couple of weeks. We're gonna put out our own guidance for more D6. I'm gonna want HIV RNA testing at initiation. Okay.
Thank you, Monica. That was fantastic. Thank you, everyone. If you have other questions, come to the front.